Ladies and gentlemen, I welcome you from Syria, from Aleppo city. My name is Abdulhamid Said Isa. I'm an orthopedic surgeon. It's my pleasure to be involved in this conference, and I'm pleased to present to you a summary of our experiences as they emerged as a result of difficult economic conditions in which we tried to find inexpensive and advanced methods suitable to our orthopedic patients that our insurance companies do not support. The idea of hybrid limited shoulder surgical management (HLSSM) is to get the least easy surgical intervention, as arthroscopic surgery begins with examination of the shoulder joint, and the location and size of the lesion are determined. Then open over the lesion with an open surgical approach that is very limited for surgical repair, not using arthroscopic instruments but conventional surgical instruments in the next step. In this picture, we can see the left shoulder of the patient. We can see 2 points in the front and in the back. One of them we can use it for arthroscopy, the other for the probe for testing the rotator cuff and the shoulder joint. We can see also this line parallel to the lateral edge of the acromion for surgical incision. We can make a limited small incision about 4 centimeters to access to the shoulder joint and rotator cuff. Clinical experience with this technique consists of 45 cases over 31 months. This study was from September 2020 to May 2023. All cases were done as one-day surgery and under general anesthesia. Identifying the full characteristics of the lesion by arthroscope, which are its size, shape, and topographic location. In step 2, we go for mini-lateral shoulder approach, MLSA, as known as second Said-Isa's approach, and we will talk about it later. This technique acquires good rehabilitation achievements in a shorter time, more rapid return to work and daily activities, a short healing period, less surgical traumatic incision, fewer tissue dissection, and less scar tenderness than in typical open shoulder release. It causes gentle scar and good cosmetic skin healing. The procedures take about 35 to 45 minutes. The disadvantages of typical surgical arthroscopy with repairing the identifying lesions include the costly full equipment required, costly surgery, and prolonged procedure time more than 45 minutes. Most importantly, there have been many reported complications in association with the procedure, including neuropraxia. In our results, the mean duration of our operation is less than typical shoulder arthroscopy. No single major complication, wound, or neurovascular was reported in any of our patients. Minor complications were observed, including 2 superficial wound infection, no wound hematomas, and no paresthesia in upper limb nerve distribution. Fibrous adhesion is effective between subcutaneous tissue from one side and the acromion edge on the other side at the skin incision zone. After 6 months follow-up evaluation, all patients were satisfied with their cosmetic results. The postoperative cosmetic appearance of the shoulder is an important issue related to skin incisions. Our results showed clearly that this technique we use is moderately satisfactory and comparable to typical open approaches. The overall patient satisfaction with the procedure was also good at the final follow-up visit after 8 months. A longer follow-up period is needed to assess the long-term results of this approach regarding the possibility of recurrence of the disease, which was not done in our study. In discussion, an open repair requires several centimeter long incision. This procedure is performed when there is a large or a complex tear or when tendon stitching is needed. During the open procedure, the shoulder surgeon split the shoulder muscles to access the torn tendon. Typically, this procedure also involves the removal of the bone spur. The all-arthroscopic rotator cuff repair procedure is performed with the help of an arthroscopic, a small, thin, flexible tube with a camera on one end. Only keyhole-sized incisions are made to send the arthroscope and surgical instruments during the all-arthroscopic repair. The surgeons use the torn tendon on a video monitor and reattach it with a small surgical instrument. Compared to open repair, many open repair techniques involve making a smaller incision like all arthroscopic repair. This technique avoids the need to split shoulder muscles to access the torn tendons. Like open repair, this procedure involved viewing the torn tendon directly rather than via a monitor. We found no difference between the two techniques and ours by scar length, complication, and rehabilitation. Our results showed that a large improvement in symptoms and function occurred in the first 3 weeks after surgery, and further improvement continued up to 2 months postoperatively. These improvements are comparable to those after open shoulder release and endoscopic ones. The average operating time in our series was 35 minutes. It is almost similar to the operating times reported by other authors who used the comparable small incision technique. The reduced scar, pillar pain, and tenderness of arthroscopic techniques were better than the ones. The postoperative cosmetic appearance of the shoulder is an important issue related to skin incisions. Our results shows that this technique we use satisfactory and comparable to endoscopic and open approaches. The overall patient satisfaction with the procedure was also good at the final follow-up visits. According to our comparison of the results, the rehabilitation of our patients was faster, and we associated it with the mini incision and the minimal surgical dissection as those less surgical trauma in the shoulder area, which means less pain and full recovery of movement of the shoulder joint faster than what is seen in both the usual method such as the usual surgical opening and arthroscopy. It should be noted that this procedure is new, as the study was published in this year, 2023, and it is subject to discussion and perhaps modification, especially after it's practiced by a wider segment of surgeons around the world and in different circumstances. Based on our study and the results of previous studies, the hybrid limited shoulder surgical management technique is not so simple but available, easy to master, safe, and cost effective. The outcomes, which are comparable to endoscopic release in many aspects, to open release, justified its use by experienced shoulder surgeons, especially in countries where endoscopic procedures are expensive and not widely available. Let's talk about mini lateral shoulder approach, the next step or the step number 2 of this technique. The dissection takes place slightly over the acromial edge proximally and over the origin of the acromial deltoid part. After revealing the region of the medial deltoid origin on the acromion, the acromion deltoid origin is gained only on the edge of the acromion. Like this picture, we can see this incision about 4 centimeters, the distal acromial edge, and the medial part of deltoid. In this picture, we can see how easy to see the rotator cuff and its tear from this incision. And we can easily put stitches from this approach, not so hard, and we can also make a chromioplasty. It's not so hard also. And here we can see a bone graft for Hill-Sachs lesion, and we fix it with a screw. Thank you for listening.